I'm going to turn it over to Jody Ann to get this conversation and start with talk about just the challenges for in health equity research. So Jody Ann, take it away.
Great, thank you, Craig, and thank you everyone for joining us today. And welcome to our first brainstorming session around health equity. One of the main reasons why we wanted to have this discussion today is that from our June 1st community call, where Patrick provided some updates on our OKRs, we all felt that we made some progress in the area, but we felt like we could definitely do a lot more when it comes to health inequities. So the goal for today is really for us to hear from you all, to hear from the community, and really the excitement that we saw, happening in the chat. How do we translate that into actions? How do we contribute to the area and really advance the science around health inequities? And for us to do that, today we wanted to hear from you all about what are some of the work that either has been going on, you all have tried to do in the past, or and what are some of the barriers that we came across, and if we were successful in overcoming those barriers, what were some of the strategies around that? I know that there has been some work done in Charybdis, and Neoma, I believe you also spoke about the Hera study. So, anyone who has done work in this area in the past will really love to hear you all speak up or utilize the whiteboard. I believe Craig might have added the link to the chat here. So, yeah. Naomi, do you want to just give a quick overview of what you've done with Hera, and then we can go into the rest of the group?
Sure. Hi, everyone. So Hera is just one example of what we're hoping we can all do in OHDSI when it comes to health equity research. And if you look at the whiteboard from Patrick, like we were thinking of where it fits, and obviously it fits within like some software development. There's an interface that kind of does a characterization study of at the gender and race level, and race is really in this case highly binary. In fact, it's only white and black patients, and we are looking at differences in prevalence across all conditions, as well as across 120 phenotypes of interest, and looking at prior to phenotype, after cohort entry, and things like that. So currently there are about 13 databases and sites, and we really are eager to restart. We definitely dropped the ball on it, and that's absolutely horrible considering the urgency of all of these questions. But we're now, I think, back to being ready to get some more sites into it, and also, if anybody is interested, and I think that would be definitely one of the interesting conversations at our working group meeting, figuring out who wants to be involved in the analysis. Like so far, like for all of these analyses, I'm thinking of Charybdis, there's so many results. There's a bunch of different analyses we could be running, and we need more help on prioritizing for sure. So this is where we stand. There's the website for Hera is live and has a lot of really nice visualizations that already are giving a very clear pattern of disparities in gender and in race, and through intersectionality of the two. And I think, again, the question is, how do we want to present, and how do we want to cluster the different types of analysis to summarize all of the findings so far?
Okay, so if we want to get the conversation going, just to kind of keep it, organized somewhat, if you could use the hand raised function, I will help, just kind of keep it going that way. But we do want to start with challenges within this research. So does anyone have some thoughts they want to share to get started here?
Sure, I'll say the, I'm sorry, I should
Okay.
raise my hand.
Why don't you get started, and then Danny will go next. But let's use the hand raised if you can, please. Okay, Danny, you go.
I was just going to say, I guess, a couple of things very quickly. One is that you mentioned, Noemi, the intersection of age and ethnicity or race. The other thing that we tend to look at quite a lot in countries like the UK is socioeconomic status or deprivation, and that is a factor that's hard to visualize working in an international network, right? But that is, such an important predictor of so many things that I think it's worth at least brainstorming a little bit on how that could work. Yeah, I think that's mine. And then regarding methods, we have done quite a fair bit of work on things like, access to care and equity in access to care using equity rate ratios and methods like that. So maybe there's also a kind of methodological conversation to be had at some point.
Andrew, go ahead.
Well, a couple of the challenges are that we have typically incomplete data within EHRs on some of the key variables around race, and there's a sort of a two-edged sword that there's a increasing emphasis on collecting social determinants data, at least in some of the EHR vendors. There's now lots of standard modules for 8 different categories of social determinants, and depending on your institution, those can be things that are collected on a regular basis, and if you're using one of those EHRs. So there's both a clear lack of completeness on some of these key variables at the person level, and an increasing opportunity to engage with institutions if you're at a care providing institution to kind of promote and use the data that's being collected on a variety of social determinants. So that's one, and I think the strategy that naturally arises is related to what we're doing in the GIS work group. Whereas if you don't have the person level data, you can start to get the environmental social determinants of health at a regional level. If you know where people live, you can use those as proxies for some of those determinants. The other is just the vocabulary. So I think, as Danny was saying, how to represent these data is part of it, what you implied, Danny. I don't want to put words in your mouth, but I think doing things on a global scale where we don't have a set of standard terminologies as we do for medical terms, for medical concepts, there's a significant challenge to coming up with the standard terms that we're going to use to represent things related to race, related to culture, related to economic opportunity, and other factors. So that's also something we're working on in the GIS work group. But I think those are some of the significant challenges.
So it sounds like what I'm hearing is that we've had challenges around incomplete data, and also just race, ethnicity, just being able to pull that out. And one of the things that we need to do is really develop a standard for addressing some of those.
Johan, you have your hand raised? You're currently on mute. You'll need to unmute.
Yeah, unmute myself kind of helps, right? No, one of the issues we have in some European countries is that it is almost illegal to record race. And I wonder whether race is really the vector of interest or whether we are truly interested in socioeconomic status. I mean, it is easier to know, at least in the Netherlands, it's easier to know the type of car driven in that neighborhood than it is to record race. It is exceedingly difficult. And it immediately begs all sort of questions on whether or not it is the first generation, the second generation, So I don't know how it is in other countries. We have an issue here, at least in the Netherlands. And it probably deals also with the fact that we had a Second World War and all. Things tend to carry over a lot. We have an issue with recording race, and would it be possible to focus on socioeconomic status?
And if I may ask, I think one of the interesting questions for us is also the fact that there are many different populations and ways of slicing and dicing the populations to think about disparities. And while race is definitely one of the dimensions, there are other dimensions in there. And as you guys all said, like social determinants of health might be a way of getting at those.
Kang Ling?
Yes. Yeah, we have the same issue also in Sweden, not in the Netherlands. We do not take in data according to race in any registries, health registries or non-hospital related registries, because it's against the GDPR law. So we are very strict about that. And I think that when it comes to those kind of studies, I suppose it depends on what is the question for the research. What are you looking for? And if can you find the information in other ways, or try to relate it to other factors that can stigmatize any particular ethnic group. So these are the things that we are looking about when it comes to looking and working on equality, so that every citizen, citizens have equal health, equal opportunity for healthcare, and so on. So we try to look at that in another way.
Andrew Payne?
Hi. We've encountered the problem of, like many people have said, there being different ways to document race. In some of our stuff, we're finding race reported as nationality, which is, we think, pretty meaningless for the researcher's intent. We've also had trouble with categories like white and black producing being such crude measures that we're seeing a lot more diversity within those groups than between those groups, indicating that that unit standard of measure is not really useful for generating a lot of insight. Yeah, maybe someone else has encountered that as well.
JD and then Aza?
Yeah, so I think the race issue, with the whole, at least from the United States perspective, there's been a lot of talk about health disparities among Black and brown versus white people. But I think, again, the race concept isn't so cut and dry. Well, it has been for years, but, people migrate and, again, I guess it's just a difficult concept. And, you start doing genetic analysis of people and I don't know, I just think it's going to be problematic personally. And I think the GDPR issue definitely is going to be something that's going to be difficult to get around. So.
Aza, you can go ahead.
Yeah, I was just thinking those challenges about the lack of data or the informative data is not new, it's known. And the literature or the work on disparity, I don't know, the last few years, it has intersected a lot with the geospatial epi work to kind of understand how we can look at disparities maybe on a group level and take advantage of the data we have and the advantages of the methods we have in the geospatial epi field. And I know that there has been some advances that we worked in our group on using location and using that in our data model. And I wondered if we could use those techniques to kind of do something about disparity in the lack of race or discomfort of using race and so on.
Asya, and then Jessica, please.
Yeah, so race-related issues has been, I'm speaking from the NHGRI perspective. So genomic studies has noticed from GWAS study that the race information cannot really correctly or more correctly to relate the race information to the phenotypes. So the NHGRIs, some researchers are promoting to use combined information such as genetic ancestry and geographic location, nationality, plus race to have a more completed picture. I mean, you might add the ethnicity here too, but the nationality, ancestry, and the geographic location are the three combined elements for maybe add race for define a more better picture of a race or the origin or genomic related information to conduct genomic and phenotype studies. This I see a lot of international cohort study. They are maybe going towards this approach. So I want to shout out here. And I think we need to, as a community, we need to come up with a kind of our agreed a set of data elements that we think will be helpful to reveal some important information about race. Race is a social construct. Only race is not enough.
Jessica, go ahead. If you're talking, Jessica, you're on mute. I can't see your.
Oh, thank you, Craig. So I'm speaking from the perspective of a health system researcher in the United States. And, you know, I agree with a lot of the comments that were made that with regards to the importance of other factors to account for and monitor health disparities outside of race and ethnicity. That being said, there's been plenty of literature, at least in the United States, has demonstrated that when you account for socioeconomic status and other factors, that disparities still exist along the lines of race and ethnicity. And we have, at least in our country, you know, continuing challenges with systemic racism and bias that does impact patient outcomes. And the only way to shine a spotlight on those issues and improve and address those issues is really by monitoring race and ethnicity. So at our health system, we're working on improving at the registration point of contact with patients, the process for collecting race and ethnicity data, expanding to start including data on other social determinants of health, including history of incarceration, factors like sexual orientation, so that we can monitor performance in quality and the delivery of our care for patients. And if there is a disparity, be able to address as a health system. And we're developing scripts. There's actually been some good research by Henry Ford, which is a health system in Michigan, that has tested different scripts on how to inquire about race and ethnicity with patients when collecting the data. It's called the We Ask Because We Care campaign, so that they understand that it's because we're trying to monitor our quality and improve our quality and make sure that we have all the resources available needed for our patient population. And so as important as it is to acquire data on other factors, you know, I think it's really important that, you know, we don't forget the realities of bias and systemic racism to be able to improve disparities. And with regards to countries that aren't able to acquire that data, that's a really tough issue to tackle. You know, we have done prior research projects where, as ASA has suggested, tied residence zip code of a patient to established census data on the demographics for their location as a proxy, although it's certainly not the best practice, but it's a potential substitute.
I'm going to turn to Kengling and then Andrew, and then I'm going to turn it back to the moderators to now frame the discussion after to kind of where OHDSI can make an impact. So, and also thank you for all the great ideas and studies in the chat. You will all have access to this chat after the call too, so you can go back and go through all of those. So Kengling and then Andrew.
Yeah, thank you very much. I just wanted to add that you know, sometimes it's not just missing data, because there's a lot of data, but rather than what is the content of the data and how we defined it. What is the information that this data is going to carry? And if the information is carried is valuable or not. So not all data is valuable. So it requires reconsideration and categorizing this data. And I mean, it's the other thing about race is that there is no, like, there are a lot of, none of us can say one is a pure Chinese or one is a Black African American or you are Spaniards and so on. Everybody comes through a line of linearity where there are in the genetics pools is very variable today. So if you want to talk about races today for data collection and doing studies, it's not going to tell you the truth. And if you look into the genetic screening, again, it's not going to tell you the truth. Both ways, I would say it's not practical. For they are not really answering the question that you are pertaining it to. So perhaps maybe think of other factors rather than turning the attention to other things and that are more either proxy or what you call it, surrogate factors that can lead you to answers. That's a better focus to shift rather than to concentrate on that. It's what I'm thinking.
So I think the, echoing Jessica's earlier comments, even though other social determinants are extremely important, I think race is distinct, even when you account for those other things. In some of the ways it's distinct are from official policies that have been in place in countries like the United States that have affected where people can live. And then there's all kinds of historical ways in which accumulation of wealth, which has lasting impacts, have been different, even when you account for current income and other kinds of factors. And so I think there's a challenge to kind of accommodate where there's information about official policies that have impacted health of communities based on race and historical factors that have led to important differences that relate to health access, health outcome, and so on. And one of the challenges I think of doing this work properly is to kind of develop strategies and resources that take those differences into account, in addition to the other social determinants that are actively being measured. So I also have a comment. I think when we note that it is particularly difficult in some regions, either inside the United States or outside the United States, to get the kind of data that we would like to have, that doesn't mean that we as a whole community should take that as a full stop on how to do it. I think where we can do this work in the regions where we do have access to the kind of data that's needed, we can, as an entire community, bring our collective resources together to help address those issues and gradually expand it. And I want to ask also if, Jake, you're interested, since we're kind of handing it back to you guys, to talk a little bit about the Social Vulnerability Index work that we've done in the GIS Workgroup and some of your efforts around automating the collection and normalization of that.
Yeah, sure. So I guess, yeah, this does maybe segue a little bit into our next topic of what can OHDSI do? Like what are the active efforts that we should make in this area? One of the things that we've been doing in the GIS workgroup is trying to incorporate these external data sets that might have social determinants of health factors in them, like for instance, the US Social Vulnerability Index, other ACS census data, air pollution, air quality data, and really just generating a large repository of standardized data in a way such that it sits next to the CDM and studies can link patients to that data if they have, appropriate methods of doing so, either by having home addresses or other addresses related to a patient, or even more granular zip code levels or something like that. So those are some of the things that we're trying to do in the GIS work group, and we're looking to really support projects who want to incorporate that sort of data. So I think there's going to be a really good opportunity for the Health Equity Working Group and the GIS Working Group to work closely together to maybe do one of these geospatial sorts of studies. There's been a significant amount of development expertise there and experts in GIS analyses. So I'm really excited for that particular cross section. But I'm wondering, what other opportunities you all think there is.
And maybe it's a good time to look at the whiteboard that Patrick started, where we were thinking that there's kind of a matrix of opportunities, and on one hand, type of studies, characterization, estimation, and prediction, and then there's advances we can do in standards, methodological research, open source development, and then specific clinical applications. And I guess, there's no, we're really at this point, we're not doing the meeting of the Health Equity Working Group, but we're trying to really get a sense from the overall community about, is there anything that's glaring at you that is the first opportunity that OHDSI should focus on? Of course, we have all the, everything in place for us to do. We'd love to hear about that. Otherwise, we have some ideas we'd like to probe you against and hear your answers.
Jessica?
So many health systems are either already implementing or thinking of implementing routine screening tools for social determinants of health. And as a tool within the EHR, that's something our health system is trying to incorporate into Cerner. And I know it's becoming more mainstream now. So figuring out ways how we can leverage those screening tools and organize that data for analysis would be a huge help.
Great. And in addition, I was trying to modify the whiteboard and I can't figure out how to, so I apologize. But if I could, I would add all of your just, ideas onto it. But I guess within the category of social determinants of health, one other idea possibly is related to the fact that we do have some complementary information within the natural language processing aspect of maybe some of the nodes out there. Especially for individual social determinants of health, that would be very complementary to the GIS working group.
Let's go Danny and then Andrew. Oh, sorry, could I cut off there?
No, go ahead. I think I was actually going to call on Danny to talk about the UK Biobank, so go right ahead.
Cool. Now, what I was going to propose is that I think the best way to move this forward is to take an idea and go ahead and do a study together, and then we'll discover, all the challenges, and we'll probably have to face them and work on them. I think I sound a little bit pessimistic when I talk about doing this, but I don't think that my pessimism is a marker that we shouldn't do it. I think we need to break this barrier and go ahead and do something, and then we'll find out what we can do. In the UK, we have so UK Biobank is around 500,000 people with something like 450,000 people fully genotyped, and then we have biomarker data, we have hospital admissions and EHR from primary care linked to that. And we've been, and also all the COVID kind of, PCR tests and all that are there. And we've been investigating the association between ethnic background and the different transitions that go from being in UK Biobank to getting tested, getting an infection, getting to hospital, and so on. And it's quite interesting. It's a very rich data set. On top of that, we also have access to CPRD, which is primary care data, where ethnicity data is recorded only for a proportion of people. There's a lot of missingness, but there is some information there that could be interesting. And all these databases have also linked access to socioeconomic status data at the aggregated level. So we have something called the Index of Multiple Deprivation, which has been stratified into quintiles. We get that through linkage from the Office of National Statistics, but that's a very straightforward process. So we can we can apply to that, and we get that within weeks of applying. So we need a little bit of preparation, but we can get quite nice data, I would say, on ethnicity, gender, socioeconomic deprivation, and all of those things together. And in the case of UK Biobank, also, of course, genotype and genome data.
Thank you.
Go ahead.
Again, I want to echo a little bit what Jessica said for the second time. I think the NLP is a really important additional resource. There's so Hongfang Liu, who's going to be presenting at a future call, has developed a really easy to stand up and very effective tool for getting all kinds of concepts out of unstructured data and putting them into OMOP form. And there's already rule sets being developed for homelessness and a variety of things around how, home security related issues. And so that could be expanded on and I think easily deployed. I think more broadly, we're at a point in this where we're testing new tools that we're building. And so it makes sense to do descriptive things and validation studies initially, I think, prior to kind of having enough faith in those things to think we can answer very complex questions that sort of rely on the validity of the data capture and so on. So it seems to me like there's some methods work that ought to naturally precede that, and then some descriptive kind of global characterization of those. And wherever we have some sources like the one like the UK Biobank or gold standards that we can test the EHR data to, we will be able to calibrate how well sort of the EHR claims data can serve as a proxy for the more confident data that we have in primary sources like that. And that's my 2 cents about the overall sort of scope of an order of operations as we start to do all this work collectively.
Andrew, I hear your point about characterization and validation as a first step. Can I, I'm thinking about prediction because as we're all very, validation oriented. Meanwhile, there are risk prediction models being deployed here and there. Any thought from the community about potential either methodological work, but also I'm thinking open source development with respect to these prediction models, and whether we think it's a priority.
Well, since you mentioned my name, I will say I think so. I think that's a very valid thing to do. And I think validation can happen at the sort of individual data component level or at the level of if we have a good sense that we should be confident in what a prediction should tell us, we can, put all of the data we have together in whatever form it is and see if the prediction accords with what we have some confidence in being in the case in the real world. So if there's really good model, evidence that we should get a particular result, which is, hard to come by, but if there is, then I think going to that level, that's a kind of validation. It's it might mean that a whole variety of kind of lower level, more granular data issues are less important or more important than you realize. I mean, that's a way of testing kind of how well the machinery works in spite of some underlying issues. I guess that's my 2 cents on if I was following your question correctly, Noemi. Does that make sense to you?
Yeah, thank you.
There's a lot of really great comments going on in the chat. Also, the whiteboard, we're starting to see a couple people putting a couple new studies on it. I'm just going to try to share my screen really quick so we can see what we have. As Noemi mentioned, the work with data standards, methodological research, open source development, and clinical applications, and then of course in the area of characterization, estimation, and prediction. So a few sticky notes that have been here, but we're leaving this open for after the meeting, so you can fill more out. I'm just going to try to move it around. I mean, there's a ton of room, so you're not limited to what you're seeing on the screen right now. Put your ideas wherever you want. Also, of course, this chat and the Health Equity Brainstorm channel we have. I think we can certainly continue this conversation, but we can also include different areas of that the work group can help lead the community. Noemi, I know when we talked, you mentioned things as like tutorials and just ways that the health equity work group can benefit the community at large beyond these studies. Did you want to kind of just mention that a little bit?
Sure, and I guess again, we want to. This is not the primary goal for the work group, but really hear from you guys about what type of deliverable would you like to see besides studies? I mean, studies is the obvious one, but is there anything that you think might be useful? I mean, I'm thinking like just on the chat already, there was like a very nice discussion about equality versus equity and what are the different populations we might want to think about. And there's all sorts of very nice pointers to work. Like I've already made a lot of notes on like, oh, we need to read this and that. Any desiderata about like what you would like, what type of activities you'd like to see from the working group? Or just studies, we can do that too.
So I think over the last 10 minutes, we can certainly kind of continue any aspect of this conversation we've had. We can go back to, if you had some thoughts afterwards on more challenges just in dealing with health equity, or, work you'd like to see OHDSI continue. I think we'll just open the floor completely here, and any thoughts or comments that you might have, or questions, or just something that you may have seen in the chat that I think you think is an especially strong point. Please feel free to join in the conversation or put it in the chat. But Jody Ann and Jake, if you had any thoughts that have kind of come up over the last 10 to 15 minutes, obviously feel free to share as well.
I guess I noticed Alicia has been an active member in the chat, and I was just wondering if they wanted a chance to speak as well.
Alicia's put a number of nice things on the chat. Jody Ann, I think you were about to say something.
So just one thing I wanted to bring up from the chat is Ruth's point about, I'll just quote her, it says, one idea for OHDSI would be to examine the disparities in care and outcomes in different settings and countries. I think Danny later on kind of had similar thoughts on that. So there seems to be some agreement around that in the community as well. And I think there's a couple of others that mentioned similar things there.
Andrew, go ahead.
Another challenge that we didn't mention already is I think there's a methodological statistical challenge around how to get rid of confounding. If you think about the really important differences that happen along rural versus urban populations and how those are conflated with racial diversity in the US, I think in other countries where there's typically a more diverse population in dense urban settings, and that's conflated with both wealth and in some ways with attitudes towards things like COVID care and so on. There are these multiple combined aspects of where we live and who's living where, and how people both are either exposed to inequities with respect to access to care, or difference in attitudes with respect to availing themselves of care or participating in public health. And so I think there's a lot of some of the interesting and challenging questions in this space require the ability to pull those things apart, and that's a challenge. And so I just wanted to underline it since it hadn't come up earlier.
I also want to point out there were some messages in the chat about SOGI, sexual orientation and gender identity, and any thought anybody wants to talk about maybe current work that they're doing, or any suggestions for interest potentially for this type of work in OHDSI and whether it makes sense. I think and the reason I'm asking in particular is because there's a lot of limitations, and there's size limitation and data quality limitations.
Noemi, this is Scott Duvall with the VA. I just wanted to say that one of the other pieces that is a limitation is that, in essence, this work could be outing people who are not out yet in the community and others. And so I think it's really an important piece that it's partnered research, that you've got really good advocates, thinking of the population that you're studying, but with all of those caveats in place, one of the biggest things that we're doing, Christine Lynch, who's a big part of the OHDSI community too, on the VA side, is leading what's called a replication center, which is kind of an open science, concept where you take, methods that are published in other healthcare systems and maybe with either other methodologies like surveys or others where you haven't had larger pieces before, larger populations before to get good answers. And we first we apply it to see if it can fit in a data kind of study framework before we run these. But let me just state, you might have heard over the last little bit, there was an announcement that gender affirmation surgery is going to be offered inside the VA. Christine wasn't the one responsible for that, but her team did a bunch of the research and provided some of the numbers that helped make those decisions so that they can be really impactful as they're being done.
That's awesome. Thanks, Scott.
We have a couple minutes left. I don't know if any of the moderators wanted to share any final thoughts.
I would say the last thing that I saw in the chat that we didn't mention explicitly, although Scott just alluded to it, is privacy preserving type of methodological research or just collaboration with stakeholders and making sure that whatever research we do is done in an ethical and just way.
Jody Ann or Jake?
Yeah, I just wanted to invite everyone here to the work group. And yeah, thanks for all the thoughts. We have a lot to think about. And if you have more ideas about how you think the work group should be shaping discussions or getting good work done, we have, they're very welcome. And please reach out to me. I'm open. We have 43 people registered for the working group so far. So I'm looking forward to all the stuff that we're going to do together.
If anybody needs any help joining the work group, I mentioned at the beginning, but certainly on ohdsi.org or in the main OHDSI teams, there's the link to join the work groups. Just fill that out, fill out health equity. That'll get you to the specific team within OHDSI teams, and you'll be able to join those calls. This chat has been terrific. Thank you to everybody who has left some questions or some comments or great thoughts. Obviously, part of the conversation, the chat, the Brainstorm channel will be left up on Teams. So there are really a lot of ways to voice your opinion, share some thoughts, some questions, just to help focus the community on how we can make an impact on this. But this was a great conversation. Thank you so much to Noemi, to Jody Ann, and to Jake for helping to moderate this, and to everybody for joining and being part of this important conversation. The recording will be up later. You'll all have access to the chat, so you can kind of go through. I know this was a fast-moving conversation, so you can see everything that happened, but the recording will be posted probably by the end of the day. So thank you, everybody, for joining, and we will see you next week to learn more about the Emmaus project.
Thank you, guys.
Thanks, everybody.
Thank you.
Thanks.